Well, I hope everybody is enjoying their digestion and the rest of their lunch. My name is Carrie Griffin. I'm a family medicine and an addiction medicine physician. I'm fellowship trained in maternal, child, and reproductive health. Together, that means my specialty has been perinatal substance use for about 12 years. If you're hanging out with perinatal substance use, there's no way that you don't get drawn into wanting to understand the world of trauma. So I'm also a somatic experiencing practitioner and a norm therapist. My first talk, so these are different, and I just want to share that. So the first talk was actually an introduction to the somatics of stress and resiliency. So a little bit of an introduction to the rubric of polyvagal theory. That will be included in some of this talk, but because I have a little bit of a different crew, please do not hesitate. We're a small, intimate group. I didn't mention this, I practice in Humboldt County, so I feel like you are my neighbors down the road. It's actually been very exciting to be here, so thank you for that. But yes, pause, interrupt if you have questions about something I'm naming, please. Let's get your needs met. So I didn't include this at the beginning of this one, but especially now that we've had lunch, the first one I just had a slide that showed some feet, but I do want us to take a moment to just like reground and re-land and acknowledge that we're transitioning. One of the things that often happens, right, in trauma is that we move too fast, right? So let's take a beat. When you're ready, if it feels good to you, go ahead and close your eyes. Take a moment to just notice where your feet are, where your seat is. Noticing where the breath moves in your body without inviting it to change or move or be different than how it is right here, right now. Taking a moment just to be grateful for the time we have together, the people who've spent time and agency and creativity creating the space for us to gather. And then since we are talking about trauma, taking a moment to find any resource within yourself. Any felt sense, any memory of safety, of peace, of connection. And just imagining that like a marble in your back pocket, so that if you need it for any reason, you can pull it out. Okay, thank you. Coming back into the room together. So in this session, we're going to review the epidemiology of substance use in pregnancy briefly, talk a little bit about the physiologic effects of exposure in the newborn period. We're going to talk about NAS, neonatal abstinence syndrome, and NOWS, neonatal opioid withdrawal syndrome, talking about them from the historical lens as well as moving into present day theory, which is really more rooted in a polyvagal approach. And then together, we're going to apply a polyvagal approach to a substance exposed newborn. So this blue line at the top shows maternal stays, and these are women who were using substances during pregnancy and a number of deliveries. This data is from the Association of Healthcare Research and Quality. This is a little bit older, and yet it's still what's published on the CDC website. I think we all know that in the last few years, as the pandemic has continued, as fentanyl has become available, that we're seeing these rates rise even more. The lower number, the green, is neonatal stage. So notice higher on every domain, particularly with stimulant use. Additionally, this is a graph that looks at 4 different obstetric outcomes that are concerning: preterm deliveries, hypertensive disease in pregnancy, postpartum hemorrhage or invasive placentation, and placental abruption. And here you can see that this is from this one on here, for every single substance that is used, you see dysregulations in the process of pregnancy, of labor, and placentation. So there are many things that we could talk about as it relates to prenatal substance use, but part of what's so interesting, particularly as a maternal child health physician, is the fact that you really do have 2 patients, right? You have this intersection between mother and fetus. And so substance use, whether it's caffeine or tobacco or kale, frankly, all of that is affecting all of these systems. So certainly the mother's mental state, her cardiovascular status, substances affect breastfeeding and penetration of the breast milk, amniotic fluid, and the placenta. The placenta is actually one of the biggest sites to talk about in terms of substance use in pregnancy, particularly because a lot of substances cause vasoconstriction. So when a vessel clamps down, that means it's less capable of doing its job of circulating and getting healthy oxygenated blood to the places that it needs. When the placenta, which is one of the only organs that we make that has a lifespan shorter than our own, when it starts to constrict, that means that we're getting poor blood flow to baby, which can mean growth restriction or lower term weights. It can also mean that we lead to a placental abruption, the placenta actually tearing away from the wall. So that's the mechanism for why we think a lot of substance exposure in pregnancy leads to some of these negative outcomes. So each substance, I have a whole other talk I do about different substances and what the effects they have on different newborns. One of the main things I want to show, though, is this. Thinking about the talk we had earlier, where we were really talking about sympathetic tone and parasympathetic tone. What we do know is that as we look at substances as a unit, cocaine, opioids, tobacco, SSRIs, or antidepressants, these all increase heart rate variability, meaning that there's a higher baseline, there's a higher sympathetic endpoint. It also increases the ratio of non-nutritive to nutritive sucking, and in general leads to greater output from the sympathetic nervous system. Alcohol actually shows decrease, more of a flattening, more of a parasympathetic dominant state, as well as continued dysregulation of the suck-swallow reflex. And then cannabis, which I think is important particularly for our counties to talk about, does lead to, again, central sympathetic activation, as well as an internally dysregulated endocannabinoid system. Part of what that means developmentally is that these newborns can have a slightly harder time regulating their own responses to pain. So the autonomic nervous system is such an interesting thing to have form, partially because, and I'll have to go back a little bit, but so in the earlier talk, we talked about the dorsal vagal, which is the reptile brain. This is the part that experiences shame. Its only safety and defense mechanism is we freeze, right? You've walked by a lizard, you see what the lizard does, it stops, it pretends it flows into the environment. That is that defense response. Sympathetic nervous system, what happens instead is we mobilize, we fight, we run, we actually are trying to engage with a threat that we're perceiving in the environment. What was new for mammals is that we developed this capacity to engage socially and survive and experience safety through the ability to engage with others. That part of the nervous system, the ventral vagal, is mediated through these myelinated, meaning there's this fatty nerve sheath which allows conduction to flow, nerve fibers. This is really interesting because those don't start forming until 24 weeks gestational age. That's the age at which we determine a fetus is viable to survive on the outside. Even more interestingly for people who are involved in developmental work, the biggest amount of growth in this part of the nervous system starts at 32 weeks gestational age until 6 months of infancy. Now it continues through adolescence, but how critical is that time of the third trimester of those first 6 months of life? And if you think about that, and you think about our policies related to caregiver leave, maternity leave, and paternity leave, what a mismatch, right? I mean, this is an absolutely critical time to be engaging and in training social engagement. What's also interesting about humans and the development of our autonomic nervous systems is that we actually are developing to be in a role of continued dependence. Now, I know that this is the era of girl boss and hyper-independence and everything else, but we really are meant to be with each other and to rely on each other. That's how we experience safety and connection. So this is actually a chart that reviews some of what I was just naming. The myelinated vagus, this developed most recently 200 million years ago, associated with the nucleus ambiguus in the brainstem. The sympathetic axis, about mobilization, it's a spinal cord reflex, specifically in the upper to mid back. And then the unmyelinated vagus, that's the lizard brain, that's immobilization, that's the dorsal motor nucleus of the vagus nerve. So each of these states is associated with specific behaviors. For the myelinated vagus, our facial expressions, vocalization or prosody, listening, all of that is mediated through this structure and cluster of cranial nerves in the brainstem. The sympathetic, we see that behaviorally show up as temper tantrums and full-on behavioral meltdown. There is a threat perceived, the threat of you have taken my toy away, and now I will completely mobilize all of my defensive resources to prove to you how you are wrong and you should give it back to me. And then there's the unmyelinated dorsal vagal, and this is the raccoon response in a sense, right? The raccoon, the lizard, we feign death. We syncopize. This is shut down. This is withdrawal. This is the kid who goes over to the corner and won't make eye contact and will just kind of hide and maybe play by themselves. So in newborns, which is really the population we're about to focus on, how do we know that the myelinated ventral vagal is working? How do we know it's engaged? So it's through the suck and swallow reflex. Now, truthfully, a newborn can only do so many things, right? So as we're doing like a deep dive, we're gonna be looking at all of these different reflexes connected to them. But this is critical. There's a reason why for anybody who's had a baby and then the nurse comes in or the lactation consultant comes in, there's a reason we're so focused on this. Nutrition is a huge part of it, right? The baby needs to latch and nurse and grow and all of the things. But this is also how we tell that that baby's in a safe place. This is the beginning of bonding. This is it, right here in an act, in an anatomic correlation of the myelinated ventral vagal and in the behavior of sucking, swallowing, vocalizing, and learning how to coordinate the breath. Now, the vagal brake is actually the whole function of the myelinated ventral vagal fibers. So once the myelinated vagal ventral fibers turn off, so as those disappear, we go into mobilization. We go into sympathetic drive. So without that, so we go from a calm baby to irritated, angry, kicking, fighting, fussing. That's the sympathetic. That's the shift. So neonatal abstinence syndrome, for a long time, this term has only been used to apply to newborns who were exposed to opiates in utero. It's becoming, as there is more research about this work, a little bit more of a general term to describe any newborn who was exposed to any kind of substance, whether it was an antidepressant, stimulant use, alcohol, during their pregnancy. Historically, the way we scored this is something called a Finnegan score. Has anyone heard of this? Nobody? Okay, this is so interesting because I talk to medical people all the time, and I'm actually really enjoying the fact that like you get to see kind of our world and frankly, aggressively how we've been charting things. So with the Finnegan score, this was created by a pediatrician and who's at UPenn, Dr. Finnegan, and she was the first person to say, I don't know that this is the best way to categorize these newborns, which is really important because 3 years ago, we've completely changed how we treat them. But what a Finnegan did was it looked at 3 areas and then started to score based on how frequently a newborn is experiencing those symptoms, how likely is a newborn to need medication to support their process of opioid withdrawal. So the first area this looked at is central nervous system disturbances. So for people at the earlier talk, or to loop this back in, look at all this material: excessive high-pitched crying, sleep dysregulation, hyperactive reflexes and tremors, increased muscle tone. What is this? This is sympathetic activation. This means that your myelinated ventral vagal is not here. So we do not have a newborn who's got a felt sense of safety. This is a newborn who is living in sympathetic overdrive and hyperarousal. Then the next category is metabolic, vasomotor, and respiratory disturbances. One of the first things you'll see, the number of calls I have gotten over my lifetime about a baby who is otherwise well but breathing into the 70s when a normal newborn rate is about 40 to 60 because of withdrawal, and people are worried that we need to do an x-ray and do an IV and start antibiotics. No, that is nervous system processing and dysregulation. So some of the things we see here are higher core temperatures, frequent yawning, mottling, meaning the skin is sort of mottled and you can see sort of the blue venous structure underneath, nasal stuffiness, and then higher respiratory rates. And then GI disturbances. So again, in the earlier talk, we talked a lot about how it's the parasympathetic nervous system that allows for resting, digesting, gives us the opportunity to unwind and reorganize. When that is unavailable, or when that is overridden by a high sympathetic tone, we get GI disturbances, excessive sucking, poor feeding, excessive spitting up, projectile vomiting, and loose watery stools. Now, with that score system, what we used to do is we would wake babies up every 3 hours and then score for those 21 things. Now, how do you think a newborn did when we woke it up and then did things like, let me do this reflex on you, let me poke this, let me take your temperature? Shockingly, many newborns scored very high. Rough estimate, how many newborns do you think in the process of withdrawing from opioids were treated with medication? Just ballpark percentage. Not 100%.
How many were treated?
How many were treated? How many received medication?
90. Less than 5.
Not 90. I love this answer. I love this divergence of answers. The answer is about 72%. It's a little bit institution specific, and we used to use a ton of different medicines. We used to use everything. I used tincture of opium when I was an intern. When is the last time you've heard someone talk about tincture of opium like they're an 1800s apothecary? Phenobarbital, which is really meant to prevent seizures. And now typically what we use is just like we would in someone who's withdrawing from heroin or fentanyl, we would use an opioid replacement medicine like morphine or methadone or buprenorphine. What happened in 2018 is a huge change, and for the medical community, which is so rooted in pathology, right? That is our orientation. 2018, Matthew Goodman, a pediatrician at Yale, published a study called the Eat, Sleep, Console process. Instead of looking at 21 domains, we looked at 3. Can an infant eat at least an ounce every 3 hours of breast milk or formula? Can the infant sleep for an hour? And can the infant be consoled within 10 minutes? If the answer to each of those questions is yes, do nothing. The other thing that's really powerful about this is it actually put an emphasis on non-pharmacological interventions. So suddenly we have hospital protocols that are talking about swaddling and feeding on demand and following the baby's cues. As a person who's worked in nurseries and NICUs for 12 years, I can assure you this seems so intuitive. It was wild that this is happening in a hospital. It is a huge paradigm shift. Now, based on this study, guess how many babies get treated with medication if this is followed to monitor their withdrawal? I love you. I love this positive reinforced attitude. It is not quite less than 5. 12%. 12%. And I also want to name, since we're in Mendocino, this is a policy that I put in place at both the hospitals in Humboldt County. Our data is about the same. It's about 10% of babies get treated with medication. So this is something that could absolutely be happening locally. It's something that should be happening in rural communities where, frankly, it's actually a lot harder for families and hospitals to support lengthy hospitalizations where babies are being tapered off their medication. So, in the other talk, I keep alluding to this like a bad boyfriend or something, like in this other relationship, but in this other talk, we talked about the window of tolerance. And this is really a theory from Pat Ogden, who's a somatic psychotherapist. And what we talked about is how up here, in terms of there be devils, these are the sympathetic devils. This is hyperarousal, high heart rate, high respiratory rate, and down here is hypoarousal. This is parasympathetic tone, this is sympathetic. There's a 2021 paper that we're going to do a little bit of like a medium-sized dive on because it really offers a polyvagal approach to treating NAS and NOWS. And it starts with this. And this is the crux of, from what I understand, this whole 2-day summit is about relationships as the capacity to heal. This is about how when your caregiver is showing up in a place of hyperarousal, feeling overwhelmed, impulsive, they're tense, they're panicked, how does that affect the newborn that they're taking care of? Conversely, the caregiver who's shut down, who's numb, who's overstimulated to the point where they're just completely withdrawn, how does that affect the care of the newborn? There's a synergy between the nervous system of the newborn and the nervous system of the caregiver. And it's within this window of tolerance and this capacity to build co-regulation that transformation and safe, steady relational connections can be made. So the Hopkins assessment tool was published last year and looks at 4 domains: autonomic tone, motor tone, state control and attention, and sensory reactivity. One of the 3 principles of polyvagal theory, so we've actually talked about quite a few of them. Co-regulation is one. We're going to keep talking about that. The other is the hierarchy of the autonomic nervous system. Lizard brain was first, then our how to fight a bear brain, and then our safe, connected, how to be in community brain. The third principle of polyvagal theory is the idea of neuroception. And neuroception is how our subconscious awareness takes in information. It's tracking inside ourselves, it's tracking outside ourselves, and it's tracking in between people to garner a sense of safety. We are constantly looking for threat. There is nothing you can do about this. You cannot listen to enough guided visualization to turn off your neuroception. This is actually part of what keeps us safe and how we are able to survive to present day. Now, what's interesting is there's this moment where neuroception, all the subconscious nonverbal input that we're receiving, becomes perception, right? So all of this brainstem sensory input then goes through our limbic system, which has been forged in whatever way it's been forged by our developmental experiences, by our life experiences. The limbic system is the home of our emotions and our affect, and then it goes to our prefrontal cortex. That's where beliefs, mental self-ideation, thoughts, judgments occur. So without belaboring this too much, this is part of what we're doing. We're using neuroception as we track ourselves and then perception as we track others, but we're still, all of it's embedded on this deep sense of neuroception. So when you're observing an infant, there's stress behaviors that you can look for. Sneezing, gagging and vomiting, tremors, defensive motor actions in either the upper or lower extremities, finger splay, yawning, averting the gaze, and then tongue thrusting and head thrashing. There's also behaviors that we can look for that are directly self-consoling. Sucking, bringing the hand to the mouth, a grasp, and then hand to foot clasp. So if we're looking at an autonomic assessment of neonatal opioid withdrawal syndrome, we're scanning for what kind of tone is there. So for high sympathetic tone, you'll see irritability. You'll see a baby who, as in that eat, sleep, console protocol, is difficult to console within 10 minutes. You'll also see, if that baby has exhausted its sympathetic drive, high dorsal vagal tone, glazed eyes, or a state called pull down. Pull down is actually a very specific state described really in occupational therapy literature. And this is where literally you will watch a baby, they collapse in on themselves. It's like their clavicles come in, they turn down, and it's a moment where to the untrained eye, you might think, oh, this baby is being such a good baby. It's being so quiet, and there's a difference. And we're gonna keep talking about how to track that. But a quiet baby, you're looking for, is this baby collapsed or is it connected? Other things that you're looking for, and notice how similar this is to the Finnegan scoring sheet. The difference is, how do we relate to the information, right? We're not waking the baby up and saying, why aren't you sleeping? I'm sorry, what's the problem with you? And then GI disturbance. I will say these babies can have significant insensible fluid loss from loose watery stools, depending on how their process of withdrawal goes. So that is actually a pretty important part to look in. And then how do we treat some of these autonomic pieces? So first, you're characterizing it. You're painting a broad brushstroke of like high sympathetic baby, high dorsal vagal baby. And then you're mitigating what are the triggers. So really slowing down and teaching your primary caregiver for this newborn to slow down. Does this baby, when it has a wet diaper, does it go from 0 to 100? Does eye contact? For some newborns, particularly newborns with high sympathetic tone, eye contact is overwhelming. You'll watch them start to thrash at the breast. You'll watch them want to turn away. It seems wild because I think we all are familiar with the idea that babies can't see very far, and they can't. This is very true. They have not myelinated the optic nerve yet. But they can still sense that there's something intrusive happening, and that's part of their neuroception that we're learning how to appreciate. Talk about external calming responses, so teaching about prosody, specific ways of touching, promoting co-regulation, and altering the physical environment if there's high stimulation happening. Maybe I can just still vividly remember this one room I walked into where Duck Dynasty was blaring. You can tell this was a while ago, and I was in rural Maine, but it was so loud, and the baby kept crying, and I was completely overwhelmed by the room. So noticing these things, and then again helping to orient the caregiver towards ways to decrease any added input that's auditory or visual. And particularly for babies who are struggling with the GI part of withdrawal, small frequent feeds. So you may give 15 cc's, so a full ounce is 30 cc's, and maybe you give 10 to 15 cc's every 30 minutes during a period of time where the GI system is really having some integration issues. So then looking at motor tone. So tone can be really high, that's your sympathetic baby. Really low, your dorsal vagal. It can be asymmetric or fluctuant, meaning it changes over time. And very common to see these low amplitude, high frequency tremors. Again, other calls from wonderful new astute nursing grads about babies having seizures. They're not usually having seizures. They're usually having tremors from this process of the sympathetic nervous system being so active. And then what's the caregiver state and how are they relating to the motor tone of the newborn? It seems wild to encourage people to just slow down, but we don't live in a culture anymore where people attend births. Many people haven't been to a birth until their own. And that means that we've really relegated this early stage of development of newborn care to this isolating experience within the home. And in the wake of that, people don't know how to touch a newborn. They don't know how to soothe a newborn. You know, we could all use two aunties that Dr. Martinez was talking about earlier. We've gotten so disconnected from that aspect of culture. And it shows in these moments when brand new moms are trying to figure out, how do I touch this thing? So when we're treating tone, same thing. And you'll see a lot of this repeats itself, but we're just slowing it down so we can keep building our assessment and then our treatment skills. What are the tones and triggers? For a lot of these babies, being undressed will bring on full-on spasms and myoclonic jerks. They will get so angry, and then it can be really difficult to dress them. Containment holding, so really tight swaddles, side lying. If you can get the baby to really accept some pressure on the occiput, that's relieving. From an osteopathic standpoint, that's actually partially relieving because it's increasing vagal tone and decreasing some of the muscular tension of the suboccipital triangle. Pacifiers are great for this. Prompt response to hunger cues, so the hungrier the baby gets, the more sympathetic tone that will be active, the more muscle rigidity that's going to fill that baby's nervous system up. And what you want to model and then teach caregivers is this slow, predictable, secure, and firm. Really, like this baby really needs to feel something against it in order to be regrounded and oriented proprioceptively in its own body. So then looking at newborn state and attention, and this could be a lecture all its own in many ways, but state regulation in a newborn is 6 domains. And for people who've been around newborns or who are parents themselves, there's an instinctive level of knowing these states, right? There's deep sleep, light sleep, that in-between space of drowsiness. There's quiet alert, there's fussing, and then there's irritable crying. What's so important is it's in that quiet alert space, that's when development happens. For newborns who aren't able to have time in that state, that's actually why we think we see developmental delays, because the quiet alert state is when you have the most myelinated ventral vagal activation, and that's when we can take in information and process it. So one of the things you're looking at is, how does this newborn transition between states? And I have seen newborns go from high, rigid, sympathetic, fussy tone into collapse, and it's happened in 10 seconds. I mean, it is really wild. And these are babies that when I used to work in an academic hospital in a level 2 NICU, we took care of 32-week babies and up. A lot of them were complex withdrawal cases. So not just opioids, but often opioids and an antidepressant and methamphetamine. And so just it's a complex nervous system. And what I want to keep reinforcing is we can get overwhelmed as caregivers or providers by, oh my goodness, there's so much happening here, but the principles are the same. You're working for the dorsal vagal baby, the person who's shut down, you're helping them find mobilization in the sympathetic nervous system. When it's high sympathetic tone, you're helping them discharge that mobilization and return to a ventral vagal, safe, connected space. So the other thing to look at is there's these 4 aspects of state. So there's hyper-alert, which I think you've gotten a sense from talking about. Hypo-alert, there's flooded. This is like the full-on meltdown before you go into pull-down. And again, the name pull-down was chosen because it is just this, it's like the whole baby collapses in on itself. The other thing to note is that caregiver state determines newborn state. And so when you are working with these families, whether it's in a hospital setting, whether it's through home visits, whether it's through any number of your agencies, for the caregiver, has their mental health been assessed? Are they the only caregiver for this baby? I've had actually a mom in the NICU right now this week who it's her 8th baby. 3 of the children are in her custody. She's been back and forth in and out of the NICU because the newborn has had such disorganized suck and swallow. We've had to place an NG tube and do feeds. And she does not have support. It's just her. And we have really been at a crux. We've done all the things that we do to check our boxes and feel good about ourselves, right? I consulted social work. I got her a transportation voucher and a gas card. And yes, those are important things. I am such a advocate and practitioner of structural care. We have to look at the whole picture and what systems are engaging in people's lives. But what she really needs is what we were finally able to give her, which was, please go away for 12 hours and don't come back and let us take care of your baby, right? Because while she is the most important treatment for her newborn, she was reaching a level of fatigue where her sympathetic tone was through the roof. And then the baby's not soothing. It was only able to nipple about 10 to 15 cc's on the bottle, whereas before it had taken an ounce. The care plan actually needed to involve, hey mom, we got you, go take a break. Other things to think about are, what was the actual birth experience of the mother? If she's had a traumatic birth, if she's needed a blood transfusion, if she's had a C-section. A lot of these newborns are being observed in the hospital for 96 hours. So part of what we need to take into account is, what is her capacity at that moment to really be present? For people who are receiving substance use treatment, sometimes your need for substance use treatment changes. You might need a dose change of medication-assisted therapy. That needs to be brought into account. And then I can't say enough about stigma. The way we're interfacing and engaging with the caregiver, just subtle things. I was privileged to sit on a project this year at Providence St. Joseph's called the Better Birthing Project. It was meant to improve relationships with birthing women in our Native communities. And the first part of the project, we just listened to birth stories. And it was one of the most devastating things I've ever had happen. I'm getting a little emotional talking about it, because you just heard over and over these moments where nurses, where physicians said things without explanation, with so much judgment, and it's up to a year later. And the thing that woman remembers that she's sharing is the fact that they told her, there's no way you know how to care for your baby, when she's cared for her 8 younger sisters, right? God, our words have power, our bearing has power, and particularly in these moments where everyone's nervous system is ravaged, because birth is wild, having a newborn is wild, everybody's coming in with low energy. This is a moment where just the subtle little extra bits of ventral vagal stimulation and resourcing that we can offer really do make a big difference. So once you've started tracking state, really pay close attention to the sleep-wake cycles and what the transitions are like. From a hospital-based perspective, clustering care, this is also true at home. So doing your feeds and your diaper changes, and if you're in a NICU setting and there are procedures to do, really waiting for one of those quiet alert states to do this. And then really, again, leaning into your caregivers, because caregiver state is the basis of co-regulation for these newborns. And then sensory arousal. So there are newborns who are hyper-responsive, so they might have huge negative responses to stimuli, particularly gaze or eye contact. Sometimes just a wall that's colored. That seems wild, but there are babies who do better when you actually move them away and towards just like a blank wall. They might become more avoidant in your attempts to interact with them. And then there's under-responsivity. Again, this is that thrust of the dorsal vagal. They appear inattentive, apathetic. These babies are just not motivated to eat. I'm thinking about this one gestational diabetic baby I had that it would just sort of it just didn't want to eat. It just didn't. It had no innate desire to eat. And it was such a good learning experience for me to see that level of discoordination between the suck-swallow reflex in the other direction. You see a lot of high sympathetic tone. That's actually easier to work with in a lot of ways. That dorsal vagal, how you wake up the drive towards mobilization, is much harder to engage with. And then you might have a newborn who is just craving stimulation, right? This is the baby where you're walking up and down and you're patting and you did the swing and then you did this thing and then you did that thing, but you can't put the baby down. I'm sure some of you have had this experience in some way, shape, or form. Very, very common with newborns who are withdrawing from opiates in particular, around that 72 to 96 hour framework. So for sensory engagement, you actually can provide indirect eye contact to start, sort of show up to the baby like a little bit of side eye, as opposed to again, how quickly are you reaching for the baby? What's the quality of your touch? Again, paying attention to individualized triggers, so noticing if a particular, even for some newborns, a particular pair of earrings or particularly patterned scrub top can be too much stimulation. And so really thinking about, how do I make this a more calm, soothing environment? And again, what's the sensory input from your caregiver, right? So if someone shows up loud and big and they're just like grabbing the baby and moving them around, much more likely to cause dysregulation in that newborn. So we think that the mechanism of co-regulation, because part of what I'm trying to do in this talk is like take all these beautiful theories and then partially just for fun, but partially just to make it internalized in a even more embodied way, because our society has decided that science is the be all and end all. Oxytocin, right? So the hormone, the physiology of co-regulation is oxytocin. Certainly, that is the hormone, one of the two sets of hormones that helps your body go into labor. It's what helps you produce milk, it's what causes letdown, but oxytocin is something we're still connected with even outside of this perinatal period. Conversely, and as others may remember from the earlier talk, when we do not have that myelinated ventral vagal, that oxytocin flow, instead we have sympathetic tone, which means we have high cortisol, high norepinephrine, vasoconstriction to the organs of the body, gut shuts down, high inflammatory mediators, and a disrupted neuroendocrine axis. So one thing that's important to note, and what this slide is aiming to show, is the connection between having upregulated oxytocin, hence your lower heart rate, your higher vagal tone, the vagal brake that is keeping the fight or flight at bay is turned on. That's also leading to more anti-inflammatory signaling and leads to less gut dysfunction. Think of how many times in your life you've been upset or worried about something and it's the gut that is feeling it, right? So particularly for newborns who are showing up with a lot of gas or bloating or colic, part of what I'm assessing at that visit is actually about bonding. It's not just, do you have reflux, do you need an H2 blocker, but what else is happening in the relationship between mother and newborn that might be leading to this amount of gut dysfunction in the infant. So I want to talk a little bit about something called calming cycle theory. So Martha Welch is a psychiatrist, and she took some of Bowlby's attachment theory and included the autonomic nervous system and Porges' polyvagal theory and Pavlovian condition. I think that was the most Mad Lib psychodrama sentence I've ever said. There were so many words in that. So please let me know if anybody needs a dive down any one of those terms. And she created something called the family nurture intervention. So this is actually a process where you would go into a NICU, or you could do this with home visits, and you would perform a calming cycle. And it starts by having a scent cloth exchange, meaning something that they started by using nursing bras, actually. So like something that was very close to the mother, often had some milk on it, and then putting that in the bassinet or the stabiliette with the newborn. And then there's nurture specialists who are doing what we're talking about here, teaching caregivers how to slow down, how to notice cues, autonomic state, particular triggers, also teaching how to touch, since we've lost that kind of ancestral knowledge. The other thing that I think is really beautiful is part of a calming cycle is the caregiver speaks to the newborn in, one, their native language. So not even what they speak now, but what they were spoken to in the first 5 years of their life. And then secondly, to talk to your baby about your feelings. I think that's actually kind of revolutionary, right? Like I feel like we have this expectation when you step into the role of mother that now you're just it and you need to have everything, and there is an aggressive amount of pressure put on any person who's in that caregiving role. But what they found even more particularly is that the mother just sharing with the infant in their native language, this is what I'm feeling, this is what this birth has been like for me, and I'm sad that you're in the NICU and I'm here and I want to go home and I want to bring you home to meet your brother, that seemed to be a huge part of what created less maternal mental health diagnoses later on and higher bonding scores later on too. Another part of the family nurture intervention is encouraging as much eye contact as possible and as much skin-to-skin contact as possible. So one of the biggest randomized controlled trials about the calming cycle showed that in a NICU where they did 4 facilitated calming sessions a week, this improved maternal caregiving behaviors at 36 weeks postpartum, decreased maternal depression and anxiety in infants when they were assessed at 4 months of age. That, frankly, sounds like a better treatment for postpartum depression than most of the things we have to offer people. So I'm going to pause. We've got about 17-ish minutes left. And we were just going to walk through a case next, but I just wanted to check in and see if there's any questions, any concerns, anything that has not landed, or it feels like there's a blind spot that I haven't addressed.
I'm wondering how long do you see the withdrawal symptoms taking from birth to, I mean, I'm a foster parent, we've taken kids home after
Yeah.
a month,
Yeah.
where they've been in,
Subacute withdrawal for a very long time.
yeah.
Yeah.
And we get them home and they're still going through
Yeah.
a lot of this stuff for
Yes.
now months.
I would say, so it's unique. I would absolutely say what research would show is that polysubstance exposure, so anytime that there's been more than one substance, you can see subacute withdrawal processes happening for months. And this is where the infrastructure really needs to be for occupational therapy, physical therapy. If we were all in different non-rural counties that maybe had more access to services, some like infant child mental health and bonding. But I would say a lot of the kids in my practice, they continue to have just that high sympathetic tone for almost the first 2 years of life. It is hard. But what's your experience been? I mean, as a foster parent, you're living it.
Yeah, well, the current placement we have is 4 months old now, and it's got, I mean, it's still highly impacted with a lot of the
Yeah.
gut stuff and sleep disturbance. The tremors are pretty much gone, but there's
Yeah.
still a lot of the other kind of more internal
Yeah.
stuff that seems to be just thrashing him.
Yeah. Yeah. Co-regulation. It's an annoyingly slow answer, and
Yeah.
I want to honor that because it is. Because it
Yeah.
is. And then it's asking so much of us as caregivers to stay connected to this calm, safe, secure place.